right? I'm not sick. I don't need help. There's nothing wrong with me. Not only are we the ones that hear this often, but families hear it even probably more frequently than we do. And this is because that lack of insight or lack of awareness into illness, symptoms, treatment, benefits of treatment, it affects about 50% of individuals diagnosed with schizophrenia spectrum disorders. And it's actually the primary reason why individuals don't follow through on treatment recommendations, especially adherence to medication. So it's something that, you know, we all work with on a daily basis with this population in particular. So this awareness of illness, insight, anosognosia, it is a multidimensional construct. And so, you know, you can have insight into some features of the illness or certain symptoms and not other symptoms. So you may say, you know, I'm feeling anxious, I'm nervous, and I recognize that piece, but you know, delusional beliefs, what are you talking about? I don't have that experience. So you can have variable awareness and levels of awareness. There is this myth that individuals who are less intelligent are, did it not share? Thanks, Harry.
Yeah, we don't have, yeah.
Sorry, let me try to reshare, hold on. Let me exit out. Did it go through that time?
It did.
Okay, sorry about that. Working? All right, there we go. You didn't miss much except my little, that's the only graphic. So that there's this myth that individuals who are less intelligent have poor insight. There's also, you know, an idea that individuals who are more ill or more symptomatic at the time, where their insight becomes increasingly impaired, where in general, it's typically stable unless you do certain interventions to improve insight. We know that improved insight is obviously associated with improved outcomes. And there's also a bit of misinformation or misnomer that as other symptoms improve, that insight will follow suit. When actually insight is really its own characteristic. It's really its own symptom independent of other symptoms. So if somebody becomes less, experiencing less positive symptoms, that does not mean that their insight will improve at that time. So what it's not, true anosognosia is not a coping strategy. It's not denial or defensiveness. It's not a volitional thing where it's prideful or stubbornness. Rather, it's a symptom of the illness itself. And it's biological in origin. So before we dive into, you know, highlights of a couple different interventions for lack of insight, I wanted to just highlight that it actually is an area more deserving of attention, especially in research studies. There's not a lot out there, I think, because it's a difficult concept to kind of get at or get to and parse apart from other symptoms. I think because it's assumed to be part of the symptom picture related to other symptoms rather than something standalone. And so the number of studies out there about treatment interventions is pretty limited. I did want to note, and one of the resources included at the end for providers is the APA guideline for schizophrenia treatment. It's the 3rd edition. Pages 8 and 9 have a really nice list of things that we should all be talking about at intake and early on and revisiting throughout. And it includes things like you know, how culture impacts idea of illness or awareness of illness. It talks about, you know, assessing for level of insight, things like that. So I just wanted to highlight that because I think that that's something that's really useful to all of us. So common interventions, before we talk about that, I just want to mention how important it is that, you know, it's a team strategy in how we intervene and how we help and work with insight. You know, it's great that all of you are here and you're working with these individuals, but, you know, it's very important that, you know, psychiatric providers, case management, everybody has a level of a solid foundation in understanding what true anosognosia or lack of insight is and how to work with that so that the individual is sort of wrapped around with these kinds of approaches. So as much as possible, you know, making sure to share information with team members and have this as part of your conversations. The techniques that we'll talk about today are things that hopefully will be useful to all of us, to all of you as well, but also to loved ones. So when you're thinking about involving loved ones, including loved ones, there are some strategies and techniques in here that can be useful to share with them. So CBT, I won't go into in much detail because you all know these. The explicit aim for CBTP is really to sort of reappraise the symptoms of the illness, which is the core feature of clinical insight. And so we can see why those two marry so nicely together, CBT working with insight. There's this fear or this idea that if people gain insight, this could lead to more depression and potentially suicidal ideation or suicidality. There's mixed reviews on that. However, CBT seems to be a protective factor in that. So if you're working with somebody from a CBT perspective, it seems to protect them from this idea of feeling more depressed as they gain more and more insight, because actually a better insight brought about by CBT can lead to improved mood rather than a poorer mood. So I think that that's important as you move forward in your work. Motivational interviewing, we've all are pretty familiar with, but it does give us some really nice language and skills and techniques to use with individuals who truly lack insight, because it can lead to increases in insight and treatment adherence. And, the basics of the basic approaches to MI that can really assist with insight are, an accurate, genuine way to express empathy, getting at those underlying emotions, helping an individual to develop their own discrepancies between current behavior and goals that they may have. It helps us to give language and skills to avoid sort of this argumentative or contradictory way of approaching things with an individual. And it really gives us a balanced way to look at the pros and cons of options they may choose related to treatment. And it also helps us to help them support self-efficacy without really the choices they make about what they choose to do in terms of their treatment is going to be up to them. The other strategy is the LEAP model, the listen, empathize, agree, and partner. This is another one, that I love, and I think it's great to share this information with families, especially loved ones. And it's Xavier Amador's approach, and I think you all have been exposed to this in your trainings with Harry and Val as well. But it's a communication strategy that's used to build trust with individuals who lack insight into illness and potential benefits of treatment. And it helps us move from this adversarial approach to a more collaborative and positive approach. It helps with treatment adherence, even if the individual doesn't agree they have an illness. And I think that that's mission critical for this kind of work. And it also really helps and can work, the strategy can work, even if the family member doesn't buy into the whole idea of anosognosia as a symptom. Even if they think they're in denial, it can still work. So I think that those are very, very integral things to know. The goal of this is not to get somebody to admit that they're sick. The goal is to really help somebody get to a place where they understand that they need help, and can get them to a place where they can learn to accept treatment. But it does take a lot of practice. It feels a little funny as approach at first. And it involves a lot of unlearning communication habits that, families or all of us get into. There we go. So I won't go into much here, but, I wanted to just mention that, listening reflectively is really the cornerstone. And it's this sort of genuine interest in what somebody's saying, curiosity, respect, but without judgment and without commentary, without making suggestions, which can be really difficult, especially for loved ones as well. But we're sort of taking a journalist approach. We're asking lots of questions and we're letting go of our own agenda, which is to get somebody to agree to, medication or other treatment. Empathize is the E. So empathizing for reasons for not wanting to accept treatment, and also with those feelings connected with delusional thoughts. So I think that there's this fear, especially by family members, but sometimes from us as well, that if we empathize or we do that incorrectly, it'll feel like we're agreeing with the delusion or the delusional thought. And the two things are not the same. And so if we're empathizing with somebody's frustrations or fears or discomfort, that's what we're trying to tap into, or this model is trying to tap into. Agreeing, looking for common ground, becoming that journalist or a neutral observer, just making observations. And when we're invited to give an opinion, we try to hold off on giving the opinion until we have a really solid rapport and high trust is built. And we still try to continue to delay our opinion because it's probably going to differ from theirs. But when we do agree to give our opinion, typically we acknowledge that this may be something that's frustrating or hurtful to them if we don't agree. And then we let them know that, we're fallible, we could be mistaken, and we may have to agree to disagree, and then you're able to share your opinion. And so it gives a really nice, language, scripts, things that people can use to practice these interventions. And it's laid out really well in his book, I'm Not Sick, I Don't Need Help. And then, of course, the P is partnering and working towards those shared goals that have been identified. So assessing for anosognosia. So this isn't something we always really consider doing in any structured kind of way because it seems pretty intuitive or clear to us when somebody lacks insight, but is it really? And do we really fully understand at the depths what this individual is experiencing? You know, there's sometimes cultural differences that can lead us to think somebody lacks insight when really there's more to it than that we just don't understand yet. And so it helps us explore this idea in more detail, which helps with obviously risk assessment, treatment outcomes, adherence to treatment. And so performing more thorough assessments of insight on a more routine basis could be really, really helpful in our work. And we all do have blind spots, and we all do have certain feelings or biases when we have somebody that we've been working with for a while who's struggling with this idea of insight into illness or symptoms. And so a structured approach can be really helpful. So just in general, if we're thinking about anosognosia versus denial, you know, looking at, is the lack of insight severe and persistent over months to years? Loved ones can help us with that. You know, they can help paint a picture of what that's looked like. If beliefs are fixed and don't change in the face of evidence to the contrary, and, you know, think about your CBT alternative explanations work, you know, if they still hold tight and fast, regardless of what other evidence or alternative explanations you present, you know, there's a good chance that it's true anosognosia. And then if they're able to sort of explain away any evidence, you know, they're masters of explaining away the evidence. Those are things that we can look for to help us discern if it's anosognosia versus denial. Oops, sorry. So assessing for insight is like we said, it's a multidimensional construct. So you have to know, you know, their awareness about having the illness and their awareness or level of buy-in to understanding the need for treatment. Also, are they aware of the impact it has on self and others? Are they aware of individual symptoms, and to what do they attribute those symptoms? Are they able to identify that it's tied to a certain diagnosis? And then, you know, psychological testing of executive functioning, if you have the opportunity to do that, or if it has been done, it can help inform our work a bit, because there's a correlation between poor executive functioning and poor insight when it comes to negative symptoms, not so much with positive symptoms. So that can be helpful. I wanted to include this table that gives different aspects of insight. So things that you can be considering, you know, like temporal aspects. So, you know, how do they identify how they were a few years ago when it came to their illness versus now versus what they think for the future, for example. So it's very important to assess all of these various aspects when you're talking to somebody. I put up here a couple of scales that I really like, and I put links to two of them that are, you know, the sort of gold standards and they're my favorites. But currently there's no measure that includes all aspects of insight. So, you know, you may want to take things piecemeal. But the scale to assess unawareness and mental disorders, you know, it looks at, you know, talking to an individual. So in the most general terms, does this individual seem to believe that he has a mental disorder? So it really gives you sort of 9 structured questions to consider. And the self-appraisal questionnaire, it is developed for use in this SAIQ. It was developed for use in a community setting. There are 3 subscales. If you combine 2 of the subscales, it's 9 brief questions that you talk with somebody about. They're things like, when somebody first recommended the present treatment plan, how did you feel about this recommendation? I think my condition will go away by itself. So if you use just those 2 scales, it gives us a really solid idea of if it's true lack of insight versus something else that's happening. So I'm happy to send you those additional questions. Just let me know if you'd be interested. So just in brief, we know higher levels of insight into illness predict, you know, consistent adherence, improved outcomes, fewer hospitalizations. We also know that the medical model, here's your diagnosis, here's education about it, here's what you need to do, does not work with individuals who lack insight. But we do know that supportive and knowledgeable loved ones and engaging them in very thoughtful and planful ways does work with individuals who lack insight. And that respectful, trusting relationships are truly the cornerstone of helping somebody with poor insight to help them to accept treatment or interventions. So loved ones really need to know what we know. They don't need to know the definition of anosognosia, although that's important. They don't need just that. They don't need just the idea that don't agree with a delusion, but don't argue against it. They really need the words and the actual skills. And we can provide that. You know, some of those interventions we talked about earlier are things that, you know, a family can actually directly implement with practice. They need to understand that the individual truly believes that they're not ill. It's not a volitional thing to frustrate them. Families, it's helpful for them to learn how to accept the realness of that individual's experience and be respectful of that, reminding them who that person was at their core before the illness. That can be really helpful for families. They need validations for their frustrations. I think lack of insight is frustrating to all of us. I can't imagine being somebody with an illness who doesn't see that and everybody's saying you're sick, you need medications, or being the family member who are trying to keep them safe and convince them that they need treatment. And so reminding families that it is a brain dysfunction. It's not an individual's choice or volition. Can be very, very helpful. Reminding them that, brains are elastic and they're amazing machines that can learn to compensate using different parts of the brain. So rehabilitation of parts of the brain is possible. So really helping them to keep hope alive. And understanding the importance of self-care and the awareness of burnout, which I think goes by the wayside a lot with families because they're so invested in making sure their loved one is safe. So that was just some final thoughts. I've included some resources for you all as providers, some resources you can share with loved ones. But like I said, if you want any more information or, those tables of questions that you can kind of just use, here and there in practice, please just let me know. Thanks, everybody. I'll shoot it back to Val.
Wonderful.